Welcome to Module 1. In this module, we will define quality and continuous quality improvement, examine different quality improvement approaches, study the different terminologies around quality management, and understand how regulation and accreditation supports or hinders CQI. Healthcare has witnessed great scientific advances in the past 200 years, all with the purpose of achieving better quality of life. We have all been beneficiaries of efficient transport systems across the world. We have witnessed the advent of the Internet of everything. Big data analytics is driving economic decisions in all corners of the world. You're probably going through this course using a system or device that was unthinkable just a decade ago. Many of us have encountered, either through in-depth medical training or as part of a science lesson in high school, a brief history of some of the greatest inventions or discoveries in medicine and healthcare. From the profound discovery of the power of hand-washing by Ignaz Semmelweis in the 19th century to the almost accidental discovery of penicillin by Alexander Fleming in the 1920s, many people wouldn't imagine surgery without anesthesia. From the pioneering work of Dr. William Morton, we have all come to appreciate the effects of organized patient nursing care, stemming from the work of Florence Nightingale. The diagnostic world has some of the most advanced technologies in the last century, but notable contribution of Wilhelm Röntgen in the last years of the 19th century. Management of patient records is an important element of all these discoveries, leading to cutting-edge patient records management systems across the world. The aircraft industry, highly regulated, safety-critical, complex and competitive industry. Yet there continues to be a need to develop innovative solutions that are client-centric to address process efficiency without compromising safety and quality. However, not all discoveries have often led to automatic translation to better patient outcomes. These and many other discoveries or innovations have to be accompanied by a system to move them from ideas to tangible deliverables suited for the client. The models may differ, mostly in names. However, one should focus on improving healthcare and steps to accomplish improvement. Identify what goals you are trying to accomplish, and then determine the most appropriate methods to achieve this end goal. What are the differences in the listed terms? These terms are all different ways to describe quality improvement. The article by Karen Walsh, mentioned here, writes about the 100+ names used to describe the different methodologies. However, they are pretty much all the same with minor variations. The general idea is taking what we know to work and applying it to every patient who needs it. Let's consider what has been our traditional approaches to improving healthcare delivery systems. There are standards and guidelines based on scientific evidence that define what needs to be done clinically to treat or prevent specific conditions. For example, capacity building ensures health workers know how to provide key interventions and support to make sure they are doing their jobs. Global initiatives have made life-saving drugs more widely available than ever, and there has been a broader use of strategies to accredit facilities and certify that they have things in place to provide special services like ART. We argue that all of these are essential and necessary approaches to improving health systems. However, we still see large gaps as evidenced by the Sustainable Development Goals, and where developing countries are today is testament to the fact that these approaches are not enough. Quality is not reserved for a few people, institutions, or countries. It is something that can be achieved by everyone and anywhere. This course will take us through the basics on managing quality in the healthcare industry. As stated by Professor Margaret Crook, Quality should be the DNA of all healthcare systems and not an aspiration for some distant future. But how do we get there? Access to healthcare has improved over the years. However, a threat to this access has been the issue of poor quality. The Lancet Global Health Commission on High-Quality Healthcare Systems published a report in 2018 demonstrating that poor quality caused more deaths than poor access, with 5 million deaths attributed to poor quality against 3.8 million deaths due to inadequate access to care. For example, improving the quality of care in the current maternal and newborn care facilities without increasing access would reduce mortalities by 50%. Healthcare in all global settings today suffers from high levels of defects in quality across many domains, and this poor quality care causes ongoing damage to human health. Across LMICs, up to $1.6 trillion is lost in reduced productivity each year due to poor quality healthcare. For some conditions, like trauma and HIV, deaths due to poor quality contribute to more than half of overall deaths. Poor quality care is not limited to LMICs. Studies from such countries as the United States and the United Kingdom reveal far too many preventable deaths due to poor quality care. These defects have high economic costs as well. An Organization for Economic Cooperation and Development (OECD) analysis found that 15% of all hospital costs in OECD nations are due to patient harms from adverse events. Globally, more than 830 million people with a diagnosed non-communicable disease (NCD) are not on treatment. What is unquantified is the undignified and disrespectful experience that people go through in poorly designed healthcare systems across the world. Now, let us take a moment and think about the last time you had a healthcare encounter. Maybe you had a routine checkup at your hospital or you visited a sick relative at the hospital. If you were to describe the encounter in not more than 2 adjectives, how would you describe the experience? Many people are full of praise of the excellent times we had during that visit to the local clinic or the main hospital in your region. But we also know of so not exciting experiences, stories of long waiting time, disrespect, ineffective care, misdiagnosis or sheer abandonment of the healthcare infrastructure by the relevant authorities. On telling the story, David Nicholas said, "Quality care is what happens at the point of service along the continuum of care, and high-quality care is a function of the system's ability to produce care that will address the client's need in an effective, responsive, and respectful manner." Thinking about the example described above, David Nicholas's definition makes quality healthcare easier to understand. It is vital to consider that quality healthcare also must be contextually and culturally appropriate. What constitutes quality healthcare in the United States varies greatly from Sweden, Pakistan, and Uganda due to context, culture, and resources. In providing care to patients, there are 6 dimensions under which the care is provided. First is patient-centered. This is providing care that is respectful of and responsive to patient preferences, needs, and values, and ensures that patient values guides all clinical decisions. Next is safe. This is avoiding harm to patients from the care that is intended to help them. Effective refers to providing services based on scientific knowledge to all who could benefit and refrain from providing services to those not likely to benefit. Equitable is providing care that does not vary in quality because of personal characteristics such as gender, ethnicity, geographic location, and socio-economic status. Timely examines reducing waits and harmful delays for both those who receive and those who give care. And lastly, efficient Efficient is avoiding waste, including waste of equipment, supplies, ideas, and energy. One needs to understand the system in which one works, usually called the health system. Variation within the processes is the major problem, and one needs to study what is good variation and what is unneeded variation. People make up systems, and one should look at the beliefs and attitudes which drives behaviors. Finally, the theory of knowledge is the change methodology one uses. Humans can figure out what they already know in order to go beyond what they currently think. Healthcare is a highly complex system with many participants involved in both convergent and parallel activities with the single aim of delivery of patient-centered care. Let's think about the type of healthcare systems that we operate in. Whether you are the credit officer, the back office supplies officer, or a frontline healthcare worker, we all need a functional system to operate optimally. As William Deming once said, if you pit a good performer against a broken system, the systems win, always. When working through improving quality of services, it is important that we look at the systems in which the processes operate. No improvement will occur without changes for the residents of the city in bottom right to enjoy seamless travel. They must suffer some inconveniences. For example, probably that section of the road may be closed for a few days. Chances of success are higher if the system is prepared for the adoption of changes. Two issues are particularly salient in this respect. One, because healthcare alone does not necessarily translate to improvement in health. There is a need to integrate all the systems and subsystems that influence health. And two, separately optimizing each component does not optimize the overall system results. For example, optimizing health IT systems for one group of tasks is not as effective as optimizing the technology to support high-quality, high-value care processes across the board. Walker and Carreon, 2009. The WHO's health system framework intends to improve the overall health in a responsive, financially fair, and most efficient way. Evidence has revealed that the framework helps to assess in-country healthcare performances. The key pillars in achieving this are access, effective coverage, quality, and safety. We will now discuss measurement of quality care and how we can measure quality. One of the most important performance measurement framework is the Donabedian model, named after Dr. Avedis Donabedian, a physician at the University of Michigan School of Public Health. He proposed a three-pronged approach of structures, processes, and outcomes that can be used to evaluate the quality of healthcare. The framework forms the basis of measurement for improvement. This slide depicts the model with structure being the physical and organizational characteristics in which healthcare occurs. Process providing a focus on the care delivered to patients such as diagnostics or treatment, and outcome being the effect of healthcare on the status of patients and populations. In defining the structure, Donabedian, one of the renowned CQI gurus, offered that these are the necessary administrative inputs, systems, environments, and structures to enable provision of healthcare. The 10 elements in the structure column are examples of structural attributes to quality. They include 5 of the 6 WHO health system building blocks. Process is where the interaction between the provider and client happens. For example, even with the best medicine in the drugstore, do we have the drugstore open in time for dispensing of the drugs? How is the work area organized to minimize waste and improve efficiency? Quality improvement is hugely a process activity that is client-centered and helps improve efficiency and minimize waste. Outcomes will be the ultimate results of the whole system, which is client satisfaction, improved quality of life, and better performance of health indicators. For example, After the quality of care initiatives are applied in the correct structure, what were the outcomes? Was there a reduction in patient waiting times and improved client satisfaction? Have the patient readmission rates fallen due to improved care? What is the difference in mortality rates after implementing quality management approaches? One important note to take is that process measures do not always correlate to outcome measures. It may take a longer time to realize outcomes from a changed process. Here is an example of straight line structure, process, and outcome. In the outpatient department, the team recognizes the need for improved provider capacity in triaging for emergency care. A training and equipment structure are put in place. How does the provider utilize the knowledge and acquired skill to improve the triage procedures or processes? After the change in the triage procedures, has there been an improvement in the client waiting times and reduced mortalities or outcomes? There are many definitions of quality improvement. While initiating quality improvement, we have to understand the different purposes of the healthcare system: to help people stay healthy, live through chronic diseases or disability, help to recover from illness, and cope with dying. All human beings go through these life phases, hence the need for continuous improvement of patients' interactions with the healthcare system. In all the definitions of quality improvement in the healthcare environment, the general consensus is that there has to be an element of improving patient care, reducing or minimizing waste, which in turn reduces the cost of providing care and ensures that patients have better experiences by providing dignified and respectful care. Quality assurance, quality control, and quality improvement are often used interchangeably. Though the terms all have to do with quality, each term have different meanings and applications. Quality assurance. Quality assurance is maintaining a certain predefined level of quality in all the products and services provided at all stages of care. For example, inspection of health facilities to ensure they have fire extinguishers. Quality control. Quality control is more of products than services. It is a process of reviewing whether the products adhere to the standards set, identifying any defect, and rectifying it. For example, a factory that produces morphine bottles for pain reduction performs a test on every bottle that is produced. While quality control and quality assurance are reactive, quality improvement is proactive in structure. Both quality assurance and quality improvement can be continuous in implementation, while quality control looks at the end line of service chain. Quality improvement. Quality improvement is an approach to constantly maintain quality levels. It includes receiving and analyzing the customer feedback and evaluating if there is any improvement possible to the existing standards and procedures. To explain this further, we can look at the Juran, another CQI Guru trilogy for quality planning. In quality planning, you identify your customers, determine their needs, and develop products that respond to their needs. In some instances, the patient's needs may not be fully known, or it could be a new service. This will need collection of information from different angles, benchmarking visits, or even simulations of the intended service situation. Quality improvement develops a process to create the product and then optimize that process, often moving from one level of service to a superior situation. Quality control creates a process that can operate under minimal inspection. An explanation of how the three quality elements apply to each other and how the understanding of all is important for quality improvement practices. While this illustration speaks to products and manufacturing, there is an analogy to the healthcare industry. We will look for planning for quality in the later parts of the course. One of the desires of many healthcare institutions is to receive international accreditation for their services due to growing demand for safe and good quality services across many populations. This is supported by increased movement of people across the globe who appreciate minimal variation when seeking healthcare services. There are several country-level and global-level accreditation mechanisms. For example, the CQI is an umbrella organization responsible for accrediting the Joint Commission International Accreditation Scheme in the US and Accreditation Canada International, as well as accreditation organizations in the United Kingdom and Europe. Joint Commission International (JCI) is considered a gold standard by healthcare service providers, a mark that is prominently displayed by organizations who have this recognition. Other bodies like COSASA in South Africa, Haute Autorité de Santé in France, the Indian National Accreditation Board for Hospitals and Providers, and the SafeCare Healthcare Standards for individual private hospitals in Europe and Africa. The most widely known accreditation globally is the ISO systems. For example, the ISO 9001 Quality Management Standards, the ISO 14001 Environmental Management Standards, and ISO 15189 Medical Laboratory Testing. It is generally understood that organization claiming ISO certification is an organization with products and services that meet quality standards. While accreditation represents a mark of quality, continuous adherence to set standards, guidelines, evidence-based care, and quality improvement are important elements in the day-to-day operations of the healthcare institution. While the benefits of accreditation and regulation are well outlined, there are difficulties in implementing accreditation processes. These are: some of the accreditations are mandatory, leading to ambiguity and attaching the process to inspection. Use of accreditation reports for resource allocation can incite compliance-only behaviors in some institutions. Ticking the boxes. Some establishments reduce quality and safety processes to nothing more than the completion of accreditation events. Cost. Too many layered costs, in some situations involving many inspectors. Some mechanisms demand for pay for a full-time inspection team to comply or monitor the accreditation provisions. Government controls. Some of the accreditation mechanisms are controlled by the government, and there is overdependence on government involvement, including funding the operations. In some instances, the accreditation is supported by external non-state funding, leading to unsustainable structure and doubts in continuity. Wrong perceptions. Sometimes, having an accreditation stamp can lead to wrong perceptions. An example is that an organization could be very efficient at human resource management procedures, while there are immense challenges in ensuring the essential supplies are delivered on time. Ignoring employee satisfaction. Employee satisfaction is an important element of quality service, so it is prudent that any form of healthcare accreditation include this metric. These are the key principles to provide a platform for quality improvement. Creating an organizational structure for CQI. This is leadership, governance, CQI teams and systems. Ensuring client-centered services. Utilizing appropriate methodologies for identification, planning, and prioritizing of opportunities for improvement. CQI measurement, tracking, and analysis. Promoting privacy, ethics, and accountability in CQI. Dissemination, sustaining, and scaling up CQI. We will discuss these elements in detail in the subsequent modules. In summary, in this module, we looked at the definition of quality and continuous quality improvement, discussed different quality improvement approaches, the different and common terminologies around quality management, and looked at how regulation and accreditation support or hinder CQI.